I'm here with Mary Vernon, who's a medical doctor and a true expert in low-carb nutrition. So, welcome.
Thank you, Andreas.
And tell us, how did you become interested in low-carb?
Okay, here's the story. I graduated from medical school right here in the heartland of America, the University of Kansas, and I was going to be a family doctor, taking care of patients cradle to grave, delivering baby, the whole spectrum. And what I noticed within the first 5 or 10 years of practice was that the information I'd been told to tell patients about how to be healthy was basically not helping any of my patients.
Okay.
So,
what kind of information was that?
Fat restricted diets, calorie restricted diets, sodium restriction for hypertension. I would give the information I'd been taught to give, I would identify the problem, and the patient wouldn't get any better. So
that's not good.
No, and well, you're a doctor, you understand.
I know.
So I was shocked, really, because this was supposed to work. So if maybe the problem is that I wasn't doing it right. So I went to the medical literature, and every night I'd come home from work, and for 2 or 3 hours I would search the medical literature, and I copied every abstract that I looked at into a file, which I then burned to a CD. I have 3 CDs.
So you
full.
spent a lot of time
I did.
studying.
I couldn't find anything that actually showed a low-fat diet worked. You know, here's a study where we got great outcomes. We got the predicted outcomes. Every time the studies would say, well, here's why it didn't happen. And, okay, well, if the point is like it doesn't happen, why are we doing it? So I was at a conundrum. If that information didn't work, what was I going to do?
Right.
And I was naive enough that I thought it was my job to go figure it out. So I didn't ask anybody. I just went, okay, how am I going to learn this? At the same time, I was studying for the board certification at the American Board of Bariatric Medicine so that I would be a specialist in this area. And I was in Las Vegas eating a steak and salad because I knew that if I ate that way, my brain would work better.
Okay.
I just knew that from experience. So I'm studying my steak, my salad, and right over here on the upper right-hand corner of the page, Andreas, the same book that I studied biochemistry from in medical school.
Okay.
Okay, same book. So I've read this before. It says, the job of insulin is to stop fat burning and enhance fat storage. Well, wait a minute. If it's that simple, if insulin is the hormone that controls fat storage or fat metabolism, this is the insulin your own body makes, then all I have to know is how to control your body making insulin, and I've got it. So
how do you do that?
The next sentence said, the primary secretagogue of insulin is dietary carbohydrate. Well, seriously, if I'd been a cartoon character, a light bulb would have come on over my head.
Right.
I mean, I just, bing, you mean it's this easy? All I have to do is take out the sugars and starches. Their bodies won't make extra insulin. They won't store fat. They'll burn fat. Everything will be good. It's really that easy? Okay, it's what that said in that biochemistry book. And I passed that course in medical school.
Sounds very simple.
It does sound simple.
How come no one thought of that before?
Well, right, and how come they're teaching it in biochemistry and then somehow by the time I've graduated, I'm told a completely different intervention? It's kind of a conundrum, isn't it? So now I had to learn, how was I going to help people not eat starch and sugar? Starch and sugar's everywhere. That's what they want to. That's what food companies want to sell.
Why?
And later on, I figured out they wanted to sell it because it makes you hungry, and then you eat more. But at any rate, I didn't know that then. So
plus it's cheap, perhaps.
And it's cheap. But the real deal is that you'll come back again if you. So how was I going to teach people to do this? There wasn't any information in the scientific literature, so I went to the lay press literature. That would mean books by Bob Atkins, Mike and Mary Vernon. So Atkins Atkins Diet Revolution, Protein Power by Mike and Mary Vernon, all the other ones. And I will tell you that after I read them, I felt that Mike and Mary Vernon had the best discussion of the science. It was great.
Yeah.
In terms of how I was going to teach Kansans to do this, Bob Atkins was the guy that knew how.
Bob Atkins, okay. Yeah.
So I thought the first thing to do is do it to me. Can I really, if what I'd been prescribing all these years was not something people could do, I didn't want to start something else they couldn't do.
You had to try it first.
Right, right. So I did it myself, and I lost 35 pounds. I didn't think I needed to lose 35 pounds. I'm sure I did, though. So I lost 35 pounds, and I've kept it off all these years. I haven't budged one bit since that time, and I still eat less than 20 grams of carbs a day.
How many years is that?
That's 13, almost 14 years.
And you've been below 20 grams of carbs
the whole
a day?
time. Yeah.
Wow.
Yeah. One time last year at
That's
Christmas.
Impressive. 13 years. Wow.
Thank you. Last year at Christmas.
I'm at 5.
Good for you. Last year at Christmas, in one of the places where I was working, I held up half an apple and said to my colleagues, okay, this is Mary on carbs. So a half an apple would be this huge carbohydrate expenditure for me. Okay. At any rate, I did that because I noticed how much better I felt. Losing weight is great. Every woman wants to be thinner. That was fine. I haven't changed clothing size since then, which, Andreas, is a bit of there's a downside. I used to have to buy clothes because I was basically not fitting in them. Now I still have the same clothes, 12 years. I hardly get to buy any because I'm the same size. So
well, that's a nice problem to have.
Okay. Well, it does help with the budget. So, okay. So now I knew how to do it, and I knew it worked, right?
Yeah.
So I just started helping patients do it. So people would come in with hypertension or diabetes, and I would say, well, I can add another medication, or I can help you change what you eat, and maybe you wouldn't have to have so many medicines. And they all say, well, doc, I don't want another pill.
Right.
Okay, fine, let me help you. And because I'd done it myself, I knew what to say.
Yeah.
So for many years, I hand wrote what I wanted them to eat. Although I was writing the same thing every day.
That's
it was
a lot of work.
In my handwriting. I would say to them while I did it, I want breakfast, eat, and then I would write it down. And okay. And at the end, I'd sign my name. Yeah. And if I wanted them to make medication changes, I would write it on that, and I would keep a Xerox copy of this in their chart. Now I have it on my computer program, so I can just basically go to menu and their name goes in it, and then if I want to put any additional stuff, I can do that. But in those days, I hand wrote it all. And so people started getting well, but not just getting well a little bit, they started getting remarkably, amazingly well, shockingly well.
In what kind of ways?
The protein in their urine went away if they were diabetic. Their blood sugar numbers normalized to normal without any medicine.
That's amazing.
They needed to come off their blood pressure medicines. Everything was getting better. I had people whose cardiac ejection fractions went from 10 or 15%, which is quite poor, up to 40 and 50%, and nothing else about them had changed except what they ate.
What about the weight?
Well, their weight went down. The whole thing fits together. You start to burn fat for fuel. You unlock access to your own fat stores. Your cells have energy. You feel good. Your cells are happy. Your heart can work better. Everything gets better.
Yeah. So you lower your insulin by not eating carbs, and then
that's it.
The body starts to burn fat and you lose weight.
Yeah.
But there are some people who say that that's not the case.
Well,
they say that the insulin has nothing to do with weight.
And you know what? That's all fine. What I can say is it's true. I'm not inside somebody's body seeing what happens. I can just tell you it works.
Right.
And that's the benefit of having the clinical practice, because what I deliver to my patients is results.
Yeah.
They get better. If they don't get better, and this is why you need a physician. If they don't get better, then it's my job to figure out why. Yeah. Yes, some people come to me so sick that there's underlying damage that can't be reversed. Actually, I've been shocked the other way. I've had people that I thought could not possibly get better who got remarkably better. So I've learned to be more hopeful.
Yeah.
And I think it's because in my the life before low carb, in that life, I wasn't using an intervention that helped people, so I wasn't accustomed to people getting better. Now, life is a joy. I go in every room to see that patient, and 9 times out of 10, the patient's happy, their metabolic risk markers are improved, their vital signs are improved, their function's improved, and yes, they're thinner. That's great too. But for me, the obesity is a marker for the problem, as well as being part of the problem.
Right. So who should eat low carb for their health?
Everybody should eat low carb.
Everybody should do it. So for whom is it most important?
Well, let's talk about that a little bit. I think of carbohydrate exposure the way I think of sun exposure. So I'm very pale.
Yeah.
If I go to Florida, California, to the beach,
Right.
I have to have a hat,
Yeah.
I have to have sunscreen and long sleeves. So there's no such thing as suntan in my life. It's just sunburn, all
Okay.
right? So I can tolerate very little sun exposure, and that's not going to change. It's not a moral issue. It doesn't say whether I'm a good person or a bad person. I'm just a pale person.
Okay, right.
Carbohydrates are the same way. In some people, carbohydrates stimulate a huge amount of storage metabolism.
Right.
And so if you're one of those folks, you need to trim your carbohydrate exposure to the level that you can tolerate. So when I go to Florida, I know to go out in the early morning hours or the late afternoon hours, not in the middle of the day. In other words, I have coping strategies.
Right.
I can still go to Florida, I just can't be out in a bikini on the boat in the middle of the water without sun protection. Okay, it's
So
the same way
thing
with carbs.
with carbs.
Every person will have a carbohydrate tolerance in their diet. So if you want to build a healthy diet, the first thing you need to start with is how much protein. Now, Bob Atkins was right about that. If you tell people to eat protein, meat, with the fat that nature packages with it, and some leafy green vegetables, and you take away the sugars and starches, their appetite will take care of it.
Right.
That information alone is enough for 90% of people to do extremely well.
So most people don't need to count calories.
Nobody needs to count a calorie.
Nobody.
No.
Okay.
Sometimes there's underlying damage to the body that has to be fixed. And there's new science, as you know, about things like this hormone system called the incretins. And yes, that's why you need a doctor. Because if you're a patient and you have these underlying problems, you need someone to help figure this out. But still, the basis for the healthy diet for everybody is the same. You start with how much protein do you need? Protein is not a percent of what you eat requirement, it's a per weight requirement. So either so much per kilo or so much per pound, but it's based on how much muscle and bone you have to support.
Yeah.
So that's the place you start, and your physician should be able to calculate that for you. Then, once you have that planned out, then you add in a fuel source. The fuel can either be carbohydrates or fat. I prefer to keep my fuel strongly on the fat side.
Right.
So because my body is good at fat burning and accustomed to it, I burn fat easily, I don't store it, and I have very stable energy. When you burn carbohydrates for energy, the energy comes and goes, you're frequently hungry, you can't perform physically as well, and so that's why I prefer using fat. And so I keep my carbs very low.
Yeah, but other people can eat some more.
I bet you probably can.
Probably.
Probably.
So what kind of carbs should you eat? If you tolerate more carbs, what kind of carbs are good? Like Coca-Cola is perhaps not the best choice.
Indeed. So for me, I would encourage people to eat real food and to eat the least processed food they can.
Right.
And therefore, most of what you eat is vegetables. Some vegetables have more sugar than others. Basically, if the plant stores the vegetable underground, it's trying to keep the sugar away from the animals. So that would be carrots and onions and potatoes, tubers, like that. They have a higher concentration of sugar, but you can have a small amount of those.
Sure.
It helps to put fat with them to slow down the absorption of, as you know, the glycemic index of fat is 0.
Right.
Fat raises your blood sugar not at all.
Yeah,
so
good.
because of that, I got very interested in helping people who already had established disease, diabetes, hypertension, kidney disease.
Yeah.
And so my patients themselves, they would come to me and I would say, look, your blood pressure's creeping up, you want to do another pill, or do you want to do diet? Oh, doc, you just tell me what to eat.
Right.
So I would write it down by hand and give it to them. They'd come back in 2 weeks, their blood pressure would be better. Many of them came completely off blood pressure medication. And so then they go to the office and tell their buddy who's just on a new blood pressure medicine, you need to go to my doctor because I don't have to take that anymore. And so now what started happening is I started getting a group of patients who were ill, who were coming in with illness as the reason to see me. And it was based on that that I carefully kept the data on my diabetic patients. I actually keep the data on all my patients. But because friends were referring friends, I was developing this practice of basically taking care of very sick diabetics.
Yeah.
Many of them, in the 13 that I published about, all of them came completely off insulin and
That's
had
impressive.
normal hemoglobin A1Cs, not with medicine.
Just
So-
by avoiding sugar and starch.
Right.
Yeah.
So most type 2s, unless they've had severe damage to their system, can often meet that outcome.
Nice. A common question I encounter is people who have trouble losing weight or losing as much weight as they'd like, even when doing a strict low-carb diet. So, do you have any tips for those people? Stuff to think about?
Well, there's
If you
all
have a
sorts
lot
of stuff
excess weight.
to think about, but the incretin system that you and I talked about earlier
Yeah.
may be failing before the insulin glucagon system does, in which case a trial of medications that support that system and help that natural signaling process to work sometimes helps to unlock fat stores.
Yeah, it does. In my experience,
Yes,
definitely.
me also. But the first step is, you know, people didn't get this sick overnight. It is a process. Some of the data that I shared at this conference showed that people had normalization of protein in their urine, but the process might take 5 years.
Yeah, so it's a long time.
Right. Well,
Same
it took
thing
them a
with
long
the
time to
weight.
get there, right? So initially, one of the great things about carbohydrate restriction is that it's very safe. You don't lose inappropriately. It's very difficult to become anorectic eating a carbohydrate restricted diet. Usually your body drops down to a level that is functional for it, and that may be more than the Barbie doll magazine looks
of
like.
course, yeah.
All right. So if you've done that, if you're doing carbohydrate restriction and your metabolic markers are normal, your blood sugar is normal, your triglyceride to HDL ratio is 2 or less, your triglycerides are below 100, all these markers of health, if you have that, then it's reasonable to just wait and continue to do the intervention. If what the point is like, I want to look like a bodybuilder, I want to look like a Barbie doll, then you may have to work more intensely with your physician to build an individualized program. But I've focused on health.
What kind of things would you recommend in that case?
Well, the first thing I do when somebody comes in and says they're stuck is I ask them to help me get data, because I can't make a good decision if I don't have data.
Right.
So I ask them to write down everything they eat.
Okay.
Oftentimes I will find a food in there that isn't obvious in terms of its carbohydrate
such as?
content. People eating chili, which has had flour added to thicken it.
Okay.
Or they'll say, well, I ate beef stew, but I didn't eat the potatoes. Well, yes, but the sauce has a thickener, that sort of thing. And the truth is that sometimes products are put in foods, and then the ingredient list, you have to kind of be a food scientist to know what the ingredients list really means.
Yeah, sure.
So if I know, and I'm having a granola bar for lunch, that's a little bit of hangover of granola's healthy, and I know that. So what I ask for next is for them to bring me a package, and I read it with them.
Sure.
Many times that alone is enough to start weight loss and further metabolic improvement. Remember, my focus is metabolic health.
Sure.
I don't really care what they weigh. That sounds outrageous. But the weight will improve as their metabolic health improves. So it's a marker for me.
Right.
I'm focused on the metabolic health.
So what kind of things do you look at mainly when it comes to metabolic health? What are the parameters that you look at most closely?
Well, I look at glucose markers. I look at lipids, and especially triglyceride to HDL ratio. That is such an easy test.
Yeah. So what's it supposed to be?
2 or less.
Okay.
1 to 1 is perfect. Above 3 means significant disease. Above 5 means you'll explode any moment.
Okay.
And so, of course, you see these people with triglycerides of 400, and now their triglycerides are 94.
Right.
Okay, that happened only with diet. And
that's a low-carb diet.
That's a low-carb diet, yeah.
Right. So anyway, we're at the American Society of Bariatric Physicians conference. How do you like it?
Well, I love it, but you know, I've been involved in the Bariatric Society for years. I'm a past president. I've served as chair of the board. Right now, I direct their internet education process. So, but bariatrics is a broader science than just carbohydrate restriction. Although, for example, if you're a bariatric doctor, you have to know about surgery procedures and how to monitor patients after that. So it's a broader look. I also have, with Eric Westman, a way to teach physicians about how to do carbohydrate restriction, and that's a company called Innovative Metabolic Solutions that really works at providing for physicians this information in the level of detail they need to know in order to be successful with their patients.
So you're trying to spread this information. I'm wondering, because you've been doing this for like 10, 15 years now, do you see any change happening?
Oh, I see tremendous change. Certainly, the bariatric physician conferences are great places for physicians who are interested to network with other people and get tips and find out how to do things. The lectures are also very high quality. As I mentioned, Innovative Metabolic Solutions is another way that physicians can access that. But yes, more and more people, more and more physicians are becoming comfortable with using this extremely potent intervention. And let me come back to that. I understand that most healthy people can do carbohydrate restriction without physician support. That's absolutely true. People on medications such as glucose medicines or antihypertensives need to be monitored by somebody that knows what they're doing, or they will get sick. And it's not because they are not getting better, it's because as they get better, they don't need that level of medication. And physicians are not trained in how and when to back off of the medicines.
So that's a big problem then.
It is a big problem, and it's the problem that Eric and I try to address when we give talks at conferences and when we have the Innovative Metabolic Solutions website.
Anyway, coming to this conference, my reaction is that very many of the lecturers are very positive to low carb.
Yes.
As for treating obesity and diabetes.
Right.
Which is encouraging. I mean, did it used to be like that a few years ago?
No, it didn't used to be like that. And do you remember when I said to you earlier, pioneers get the arrows, settlers get the land?
No,
yes, I was one of the people that took the initial arrows to get here.
Now hundreds of settlers are scrambling to get the land.
But that's good. There's so many patients. 3 out of every 4 people in America will need this kind of intervention. 3 out of 4, because they have one of the diagnoses that gets better when you treat it with carbohydrate restriction. So I think there's plenty of patients for everybody.
That's many patients.
We need more bariatricians. We need more bariatricians all over the world. Sweden, UK, look at the Middle East, look at the Far East. All of those countries, they are doing bariatric surgeries on children at Tokyo General.
So what should we do?
We should drop the carbs from our diet.
Yeah, but how do you make people understand that?
Well, I don't know that you can make them understand, although it really seems to me that the Margaret Mead approach, if you want to change the world, remember that one person can do that, doing it person by person really does have a logarithmically expansive effect. When one patient gets better, their friends know, then 2 or 3 of those people come, and then they tell their friends, and soon I have all the patients I can take care of. So everybody that can do this without a doctor should do it. They should do it according to one of the many easily accessible books. The book that was written by Finney, Volek, and Westman called The New Atkins for the New You is very good. The Finney Volek book called The Art and Science of Low Carbohydrate Living. Eric Westman and I wrote a chapter in the obesity handbook that's available from the American Society.
Mainly for doctors, right?
Right, mainly for doctors. But all that information is available. And then, of course, I wrote Atkins Diabetes Revolution. It's currently out of print, but you can get it on Amazon. Oh, just go get a copy. What do you care somebody wrote in the margin? Just get one of those ones that you know
Sure.
is being recycled. The information's there. So patients can have access to it. People who are healthy should do this without physician monitoring if they are comfortable. Physicians should learn how to monitor and implement this extremely potent strategy. And patients,
and they can come to innovative metabolic solutions and learn.
They can get credit for it. And if they want to come to one of the on-site meetings from the American Society of Bariatric Physicians, they can do that as well.
Yes.
So there's multiple opportunities to learn this information. If you're a physician, this is one of the most effective interventions you can do, and it completely fits with the national guidelines.
It does?
Well, yeah, because you know what? You go to the American Heart Association website, the kidney website, hypertension, cardiology, they all say lifestyle intervention should be number one. This is lifestyle.
Sure.
All I'm doing is helping people change what they eat.
But what about all the fat? I mean,
Well,
if
what
you
about
follow
all
the
the-
guidelines, you're supposed to be below 10% saturated
Well, no,
fat
the-
to 7% saturated
No,
fat.
the American Diabetes Association said that low carbohydrate diets are better for glycemic control, and
Well,
that
yeah,
you should
obviously.
have.
That should be obvious, right?
It should be obvious. It is obvious. I'm glad they were able to go with the science. But they said that, and then they said dietary intervention may require an individualized approach. It is absolutely true, Andreas, that I can't guarantee that the person sitting in front of me in my clinic today will need low carbohydrate intervention or will do well with it. They might be 1 in a million, and I don't know it. So the only guarantee against that's the same problem for people taking aspirin. Some people die from taking aspirin. You know that, right? You're a doc. Can you tell ahead of time?
No, of course not.
If you could, you'd fix it.
Well, so, sorry, but you've been doing this for a long time with patients. Do you see any big problems? Do you see any patients, becoming sick from this?
No, but I monitor closely. And so that's the point. I can't predict who might be sick. So the way I know is I watch them. And that's appropriate. Just like you start somebody on a new medication, you don't say, here's your new antihypertensive drug, come back in 3 years.
Right.
So it because it's extremely potent, if you already have illness or are on medicine, you need that level of monitoring and support in order to make certain that you're not ill.
So what's most important to monitor?
Well, vital signs. If you're actively losing weight appropriately, to pull the medicines away in the right order, to make sure that blood sugar levels don't go too low.
Right.
Because
if you're on insulin, for example.
Or even some of the oral medications that make blood sugars drop.
Right.
Yeah.
Yeah, it's true.
Yeah, but that's okay. When you get put on that new antihypertensive, the antihypertensive folks make that little package insert thing, and it says you're supposed to come back in 2 weeks for a blood test and then in 4 weeks for a recheck. That's because the medicine can have unanticipated effects. So I want to make certain that my patients are as healthy as they can be, as fast as they can be, without bumps in the road. And to do that, I need to see them, monitor them, and make appropriate changes. Now, after a while, they get very good at doing this themselves. And if they're stable, they don't need me anymore. If they're not on those medicines anymore and they've been very successful, I see them 3 months, 6 months, and then sometimes they just come in annually, wave at their annual physical. We look at their blood work, it's still good, they're still feeling great, see you next year.
Everything's fine. So once a year.
Yeah.
That's nice. Yeah, it's been an interesting interview. Do you have any final tips? I mean, if someone is interested in trying a low carb diet for their weight or for their health, what's the most important thing to think about?
Well,
where do you start?
Absolutely, this is a healthy way to be. Again, start with the right amount of protein. And if you want to calculate that, Mike Eads' book gives a pretty good way to do it. Although, really, you can just say 1.2 to 1.5 grams per kilogram lean body weight. That's the minimum amount of protein you eat. Eat the protein with the natural fat that Mother Nature puts with it. Don't be taking the skin off the chicken and get the high-fat hamburger. Don't get the low-fat hamburger. Okay, eat like that. if you can get close to 30 grams of protein a day, 30 grams of protein per meal, that helps to stimulate muscle function, the making of muscle, as opposed to the deposition of fat.
It's good to get some protein every meal. Basically.
It is good to get some protein every meal. And then once you do this, all you have to do is monitor those markers like the triglyceride to HDL ratio, which is much more important than somebody's LDL.
Yeah.
And since almost all of these problems that we have, the cardiovascular disease, the kidney disease, those are all driven by the underlying glucose abnormality. You take away the glucose abnormality, you don't get that other stuff.
Yeah. So what's going to happen, just finally, what's going to happen if everybody gets this and all the people with obesity and diabetes and hypertension starts to remove the sugar and starch from the diet? What's going to happen?
Wouldn't that be great? I could have another career doing something else.
Revolution all over the world.
Right.
It could be massive, right?
It could be massive. And we wouldn't have to put so much energy into disrupting the environment to develop large amount of grain, because if you don't have to have grain-fed animals, you can have animals that actually manage to make it on their own.
Sure.
Certainly in Kansas we have grass-fed beef, we have free-range poultry. One of the things that's very interesting about this is that you spontaneously decrease your intake. So in some studies, for example, the Bowden study, which was done in a hospital, the people that did low carb decreased their daily dietary intake by 1,000 calories. If everybody over the world—
Without counting calories.
Right. If everybody over the world decreased their intake by 1,000 calories a day,
that's good for the environment too.
Do you think it's good for the environment too? So you think that would lead for sustainability?
Absolutely. When is this going to happen? When are people going to
You tell me. You're the guy that's out there doing the media stuff. I just do that day-to-day taking care of patients and educating physicians. Without you,
content moving in the right direction, right?
Well, I hope so. And what I hope I'm doing is carefully assessing my patients and sharing that information with other physicians so we can get better and better about making this a smooth transition for patients.
Yeah, and you do that very well. So
thank you.
Thank you.